Welcome everyone to Talking PAH, a live CME webcast series. I'm pleased to present with my co-presenter, Dr. Sonja Bartolome, Advanced Cases in Pulmonary Arterial Hypertension. The CME is overseen by the University of Nebraska Medical Center, and the program overall is supported by independent educational grants from United Therapeutics Corporation, from Bayer US, and from Actelion Pharmaceuticals, a Janssen pharmaceutical company of J&J. I'm a professor of medicine at UCLA School of Medicine, and I'm director of the Lou Center for Pulmonary Hypertension at Harbor-UCLA Medical Center. And my esteemed co-faculty is Dr. Sonja Bartolome, who's professor of internal medicine, pulmonary and critical care, medical director of the CTEP program, and associate director of the PH program at UT Southwestern. Today's learning objectives are to list the routine monitoring requirements for patients under treatment for PAH, to describe parameters associated with disease progression in patients under treatment, describe practice protocols when managing the pregnant patient with PAH, and finally to explain the various treatment options available to clinicians in designing PAH-specific treatments for patients failing to respond adequately to their current regimen. Again, these cases are for advanced discussions in pulmonary arterial hypertension management, but in order to get everybody on the same page, just a brief summary of what pulmonary hypertension and PAH are. First of all, the most recent definition from the Sixth World Symposium puts the mean pulmonary arterial pressure cutoff of 20 millimeters of mercury. Anything above 20 is considered pulmonary hypertension. It's a hemodynamic definition for the condition. In order to have precapillary PH or PAH, you need to have that mean of 20. In addition, you need to have a pulmonary capillary wedge pressure that's 15 or less, realizing that 12, 13, 14, and 15 are really not normal, but allowing for RV-LV interactions, the cutoff is 15 millimeters of mercury, and that's nothing new from previous definitions, nor is the PVR requirement that the PVR is greater than or equal to 3 Wood units. And as a reminder, there are different groups of pulmonary hypertension. We're focusing on the group 1 pulmonary arterial hypertension, which is essentially not group 2, group 3, group 4, or group 5. There is a diagnostic algorithm that many of us use. This one comes from Adani Frost as the first author in the European Respiratory Journal that describes the diagnostic algorithm for pulmonary hypertension patients from the proceedings of the World Symposium on PH. And it goes along a typical diagnostic line of reasoning where you have a history or something to suspect pulmonary hypertension, and then you go through the workup excluding groups 2, 3, 4, and 5, hopefully fast-tracking patients that are high risk for referral to an expert center, and then the expert center takes over and finishes the workup and arranges for appropriate treatment, including these tests like VQ scans, right heart catheterizations to confirm the diagnosis. And then there is a treatment algorithm also, and this comes from the European Respiratory Journal guidelines, sponsored by the ERS, ESC, and ISHLT. And once you have a confirmed diagnosis, hopefully by that expert center, if the patient doesn't have any acute vasoreactivity, then they're classified into low or intermediate risk versus high risk, and we'll talk a little bit about what that does and doesn't mean, and then therapy is initiated. These guidelines are focused on low, intermediate, and high risk criteria that are defined by certain characteristics or phenotypes of each individual patient. We'll talk more about that in the future also. And so with that brief background, and hopefully, again, this is a case of advanced this is a program of advanced pulmonary hypertension cases. And so case 1 is a patient on oral monotherapy. And this particular patient is a 54-year-old female diagnosed 2 years ago with hereditary pulmonary arterial hypertension. Her hemodynamics at diagnosis are right atrial pressure 12, a mean pressure certainly well above the 20 definition of 47 here, and a pulmonary capillary wedge pressure well below the 15 cutoff at 6, with a cardiac output of 3.4 and a calculated pulmonary vascular resistance of 12 Wood units. She has other markers at baseline. 6-minute walk distance is 340 meters. Her BNP is elevated at 202, and on echo shows moderate to severely dilated RV with a moderate decrease in RV function. Let me just pause here and ask Sonja, what do you think about this patient initially before starting therapy? We're going to talk about what happened to this patient after started therapy, but where would you put this patient in terms of risk, just based on what we have here?
So risk-wise, she has some things that are in the intermediate range, but she also has pretty concerning hemodynamics. Right atrial pressure greater than 10 is certainly concerning. I don't have her PVR at 12 Wood units is certainly high by anybody's standards. She has a big dilated right ventricle and decrease in function. And so, and the other thing I'd like to point out is she has heritable PAH, which, as we have discussed on other programs, gives you a higher risk for decline over time compared to someone with idiopathic PAH. And so, given all of those things, I'm certainly concerned about her and would be looking at pretty aggressive therapeutic management.
Great. So in addition, there are physical findings here showing that her JVP is elevated. She has an RV lift. She has loud TR and PR. Lungs are clear. The abdomen is unremarkable. She has lower extremity edema that you can see in the photo here. And she doesn't have ascites. The patient was started on sildenafil 20 milligrams TID. And so 6 months into this monotherapy, she's been adequately controlled, however you want to define that. She's functional class 2. Her walk is now greater than 380 meters. Her BNP has dropped to 120, but the echo still shows moderate to severe RV dilatation and a mild decrease in RV function. And 4 months after that, her walk drops again. Her BNP goes back up. Her Lasix requirement goes up. And a repeat echo, again, shows no change. Connie, let me just ask you, where do you weigh these individual factors? In other words, what if the echo looked bad, but the BNP was low? What if the walk was low, but the functional class was also?
Yeah, I think most of us look at them as a whole, and that's what makes follow-up of pulmonary hypertension complicated, because I don't go by any one parameter, certainly, but usually what you're going to find as you follow folks along is more than one thing is moving in the wrong direction. And we see that in this patient. Although her BNP isn't horribly high, her echo continues to show that moderate to severe RV dilation and some decreased function, and her walk's declining. So I usually am going to go with my trends. So I don't treat numbers instead of patients, but in my clinical experience, they tend to all go together.
Okay, so here's the echo. The long axis view here on the left. Parasternal long axis is what PLAX stands for. And this shows us the patient who is lying down, and you're looking from their left arm into their right arm. Their chest is on the top, and their back is at the bottom of the image. This is a great view in general for echocardiographers because it shows you the aortic valve, the mitral valve, the left ventricle, and the right ventricle. It's probably not the best view for somebody looking at PAH, although in this case, it's pretty obvious that the right ventricle, the big black space on top, is very dilated, and the left ventricle is very small. If you go to the parasternal short axis in the middle, the PSAX, then you can see that left ventricle now, it's coming at you. It's very small. You can see the mitral valve opening and closing, and you can see the septum between the large right ventricle on top that is flat. And if you tilt your head to the right a little bit, you'll see that the left ventricle forms the letter D. So that's a D-shaped left ventricle, flattened septum. And then very telling on the far right, the apical forechamber, we're looking at the patient as if they're standing on their hands with their back to us. So their feet are up in the air and their hands are down below. And the right ventricle is the upper left part of your screen. The left ventricle is there also. You can almost not see it, as well as the left atrium. They're very, very small. They're underfilled. And of course, the right atrium now you can see very well in this view is also dilated, and you can see the tricuspid valve opening and closing. The ECG shows findings consistent with pulmonary hypertension. That is, there's right ventricular strain showing T-wave inversion and ST segment depression in the anterior V1 through V4 leads. And you also see right axis deviation with a predominant S wave in lead 1 in the upper left there. And overall, the ECG is consistent with pulmonary hypertension, but it doesn't tell you what type of pulmonary hypertension, just that it's enough to have caused right ventricular abnormalities on the ECG. So we showed you this before. I promised we'd go back to this. The amazing thing about this chart is that what we have defined collectively as experts in the world as low risk is only at 5% one-year mortality, which is typically seen in PAH patients who are young women. So we're talking about heart failure where we have 10-year mortality. This is one-year mortality. And we consider that 4.9% one-year mortality for this young woman is an acceptable, if you will, low risk. And it's defined by some of these features that are listed here, which of course are not all encompassing. And one of the things I think that really isn't well vetted in this particular table is what we just saw, the echo. So the echocardiogram, I think, is a very important, is a very potent telling story. And the only thing we have here in this table for imaging is just RA area and the presence or absence of a pericardial effusion. So the green light is low risk, the yellow light is caution, intermediate risk, and the red light is high risk. I think you'll find that we'll be talking about this later, that even in the intermediate risk patients are really not a goal, and they're not going to do well. So there's something known as the REVEAL registry, and from this registry, which is about 3,500 patients that were phenotyped and followed over time in the U.S. In several centers encompassing 3,500 patients, and developing a score with which you could predict outcome. And so the REVEAL score, and then the REVEAL 2.0, which came after that, and now the REVEAL Lite, which is designed to be a much more compact and easy to use system, is really a way to define or predict clinical worsening at one-year follow-up. And we know that the risk category is a point score system, so you're considered low risk if you have a score of 6 or less, intermediate if you're 7 or 8, and if your score is 9 or greater, then you have a high risk. And what you can see here on the left is that REVEAL 2.0 score, and then on the right, the lighter score. Again, the lighter one is meant to maybe better integrate or more easily integrate and be more and facilitate more use in the clinic so that at least everybody can get on board and use the score. Dr. Bartolome, do you use this score in your practice, and is it in your EMR? Do you add it to your EMR?
Yeah, we actually do use it in the EMR. We have a smart phrase you can just type in, and that risk score will come up for you. We also do use the French diagram, and so put both in our assessment of our patients, just making sure we've checked all of the things that can go into risk.
Great. So there's a little pop-up here that there is an app you can download. It's a free app, and you can put that into your phone if you're in the clinic and don't have it in your EMR, if you don't have that smart phrase. In this case, this woman has a score that we add because she has the wrong subgroup, if you will. She gets 2 points. She gets a point taken away because her 6-minute walk test isn't that bad, but she adds a point back for BNP. So she has a total score of 8 because her baseline is 6 plus the 2 that's added on. Everybody gets a 6 to start, and you either take away or you add. So her score is 8, which puts her in the intermediate category. If you look at the area under the curve, sensitivity versus 1 minus specificity, that gives you the highest if you have an area under the curve of 0.5. And the higher, the better. The closer you can stretch that red line over to the top left of 1.0 and over to the far right of 1.0, the better your C statistic is for reliably predicting outcome with scores. And so this slide tells us that compared with Compara and even with the French Pulmonary Hypertension Registry, that the REVEAL 2.0 risk score correlates better, as a better predictor, if you will, of outcome. What this slide shows is that there is a threshold. Let's use the 440 that was used, defined in the ERS-CSC ISHLT guidelines. And if you're below the threshold, you start to fall off in terms of 1-year survival. If you stay above the threshold, that's a pretty flat curve there. In addition, if you look at percent change in 6-minute walk, everything does, patients do pretty well when they go up maybe about to minus 5% change. So -5, +5, things are pretty flat there. Not much gain from an increase over a 6-minute walk from baseline, but a much bigger steep drop off. And if you look at only newly diagnosed patients in the REVEAL registry, 1-year survival really starts to drop off when you get below 5% worsening. Looking at the French National Database, this is what Dr. Bartolome referred to, and we use it as well, especially when we're teaching our fellows and getting them to understand how to achieve low-risk score. So instead of having high-risk points added, we have low-risk targets, and the more low-risk targets you have, the better your overall survival is. So if you look at the criteria, getting to low risk means anything functional class 1 or 2, a walk distance greater than 440, a right atrial pressure greater than 8, and a cardiac index of greater than 2.5. If you have all 4 out of 4 criteria, you have close to 100%, very high 90s, 5-year survival. However, if you have 0, then you have close to 40% 5-year survival. So really predictive here. Now, what about the patients who don't have the hemodynamics at every visit, because we don't do a right heart cath at every visit? Functional class and 6-minute walk were left in, but the hemodynamics were substituted by BNP. And if you look at the same sort of display here, 5-year survival, if you have 3 out of 3 low risk criteria, is very high, and it's close to 40 if you have none. Okay, so getting back to this patient, how many low risk criteria did she have? Functional class 2, walk greater than 440, BNP less than 50. She only had 1. And the circle in red here is around the orange line that puts her survival around 60% 5-year, 54-year-old newly diagnosed or recently diagnosed patient. A teaching point here, guidelines recommend a flexible approach to risk assessment using multidimensional stratification according only to modifiable clinical functional exercise, biochemical, echo, and hemodynamic variables with known prognostic significance. And we can't modify her heritable type of pH, but some of the other things we can modify. And we should categorize patients as low, intermediate, or high. If you ask me, we should categorize them as low or not low. You agree with that, Dr. Bartolome?
I agree, yes.
Okay, let's talk about therapies then. We know that there are 3 different pathways that we target. The endothelin pathway, we try to block endothelin. The NO pathway, we try to enhance NO. As well, we try to enhance the prostacyclin pathway. And we have oral, IV, sub-Q, and inhaled drugs to do this for these different targets. If you look at the treatment options based on the type or the class of agent, you can see all these and how they're given oral, inhaled, IV, sub-Q. And if you look at the recommendations in that ERS, ESC, ISHLT guideline, you can see that the decision tree here, or the process with which we recommend treatments, is based on strength and level of evidence. And so for the green, we have a grade 1 and a level of evidence in blue of B. For functional class 2, 3, and 4. You see nothing here for functional class 1 because there really is little evidence in clinical trials for what to do with newly diagnosed functional class 1 patients. Nevertheless, these are just determined essentially by the strength and the weight and the level of evidence. If you have only 1 trial, you get a level of evidence B. If you have multiple trials, you get a level of evidence A. And if you don't have any randomized clinical trials, you get a level C, which is expert consensus as determined by the committee writing the guidelines. So these guidelines recommend initial oral combination therapy for patients at intermediate risk. And this patient should be prescribed multiple oral agents from different classes for added effect to ensure the patient may achieve low risk status. There's some notes here about contraindications for PDE5 inhibitors and selexipag. If you look at the French PAH registry, the impact of initial survival, whether it's triple or dual or monotherapy, can make a difference in this one study. So triple combination therapy had a statistically significantly better 5-year survival in the 90s versus in the 70s to 80s for anything short of triple combination therapy. In the PH Association registry, the FAR registry, you can look at these mortality trends 1-year, 2-year, and 3-year based on different registries over time. It doesn't look like much has changed. What we do see, though, is that the low risk, the intermediate, and high risk, based on their 1, 2, and 3-year stratification, does change. And so basically what these registries are telling us that there is a way to still stratify these patients, and no matter how you slice it, no matter how you cut it up, whatever registry you use, that as risk goes up, there is a strong correlation with outcome. So the risk data is real. Now, here's one observation that we found from the REVEAL study, which is the use of parenteral prostanoids by the time the patient, or at the time of death, in the REVEAL registry. So individually, if you add these up, the 11.2, 5.6, 15.1, and 11.2 come up to 43.1% of patients that had been on prostanoids when they died. Now, we all know that patients can die suddenly, but oftentimes their death is heralded by worsening. And over 50% of these patients who died weren't on prostacyclin therapy. So that's a little bit shocking, but maybe not surprising. And I should say that this registry was among experts, like Dr. Bartolome and myself, where we either failed to recognize the necessary treatment for these patients who were probably at higher risk than low risk. Maybe there were some barriers, or maybe there was sudden worsening, and we didn't get a chance to put them on there. But we need to do much, much better than 50% for those patients. The timeline for randomized controlled trials is seen here. The first trial being epoprostenol. One of the more recent trials was the Freedom EV study. These are all randomized controlled trials that were really trials that led to the approval of drugs for the most part. There were some that were post-approval. Most recently, the Ambition study, which was a study not of drug approval for registry, but rather a drug strategy showing the benefits of combination therapy. So what treatment strategy would you use? Would you add on one oral therapy? Would you use combination therapy, including inhaled and parenteral prostacyclin? Or speaking of this clinical trials, would this be a good candidate for a clinical trial? Why or why not? Sonja, I use the clinical trial as sort of an arm for, if you will, of a three-pronged attack, meaning that if the patient is not only willing, but I feel that it's safe to be in a randomized placebo-controlled trial, I will often offer these patients opportunity in a trial.
Yeah, I think that's a good point. We do that also. But I would add that unless it's a trial of already FDA-approved therapy, we usually put them on therapy for about 3 months and enroll in a clinical trial. We rarely do placebo-controlled trials, certainly in patients who are naive, but most of our trials are that way now. But I did want to come back to you in your case. So this patient was put on monotherapy. Is that what you would do with her if she came to clinic today?
No, absolutely not. And I think even 2 years ago, most of us wouldn't have done that. If you look at the guidelines, they talk about the residual role for monotherapy, and there have even been some debates about, is there still any role? Who would get monotherapy? And I think some people could argue that certain populations might get monotherapy. Certainly not this patient. Even if she were low risk, in fact, the data really support combination therapy, as we mentioned, that Ambition study is one of them, and there are certainly several others looking at combination therapy outperforming monotherapy, absolutely. So the answers to these questions are really not simple. There are no always right or wrong answers. Any option discussed has the potential to provide clinical benefit. Really, the thing is, the most important thing is get them to an expert center and let the experts make the decisions. Decision-making should take into account patient preference. Of course, some of them aren't always willing or able to deal with pumps and lines, et cetera. And then we already talked about the clinical trials. So just to conclude this case, the evolution of PAH treatments has progressed from initially palliative only to a now growing list of medications that can modify long-term risk, targeting 3 different pathways available in 3 different forms of administration. And PAH can be rapidly progressive, and this provides the theoretical basis for aggressive upfront treatment to gain maximal control of the disease. And I think we've gone beyond theory now. I think we've really proven that upfront and a more aggressive therapy does make a difference. The treatment strategy, however, has to be individualized to every patient. We have county patients in a safety net hospital. Some of them don't even really have places to live. And so it's very difficult for access to certain medications, certainly anything that's device related. Guidelines driven by large randomized controlled trials have begun to provide direction as to initial and follow-on therapy choices available to applicable to most PAH patients. The current paradigm of PAH therapy is to achieve and maintain a low-risk status. So low or not low, that's really the only binary question. And then finally, initial combination strategies should play a central role in managing PAH to provide patients the best chance for achieving low-risk status. So that takes us to the end of case one, and thank you for staying. I just hope that you stay a little bit longer and talk about case two, which is an interesting patient in that this is a pregnant patient with PAH and presents a whole bunch of different concerns and approaches. So Dr. Bartolome?
Yes. I'm happy to present this case. Certainly a difficult one, no matter what, if you're at a big center or someone who's not at a big center to manage. There we go. So beginning this talk, the recommendations are still to avoid pregnancy. And this has always been a difficult discussion for us. Many of our patients are young women, but all major guidelines recommend against pregnancy in patients with PAH. And we're going to talk about the physiology of why that recommendation is in place. But I think it's important to also differentiate having a family and being able to carry a pregnancy with your patients when you're discussing these things. So I do talk to my patients about other options, such as adoption and surrogacy, which I have several patients who have gone through and done that while avoiding the dangerous physiology associated with pregnancy. So there are many reasons pregnancy is not recommended. We're going to talk about those. One of them is some of our drugs we use cause birth defects. Specifically endothelin receptor antagonists and riociguat will cause birth defects. They're pregnancy category X. And because of that, we require effective contraception of our patients, and we test them for pregnancy monthly when they're on those drugs. If a patient does become pregnant, all major guidelines recommend counseling about terminating the pregnancy. But if patients do want to continue the pregnancy, they should be referred to a PAH specialty center with expertise in the situation. And the reason for that is because difficult situations like this really require a team. I alone could not go out and do the same things I do with my team here if I were to go to somewhere else or a rural place without the resources and team that I have here to keep the patient alive. So you really need a lot of people with experience managing the patient for them to do well. There are several physiologic changes of pregnancy that are poorly tolerated by a person who has baseline pulmonary hypertension. First off, the uterus obviously is enlarging, and as it enlarges, there's mechanical compression of surrounding structures in the abdomen, notably the IVC, which is giving that return back to our right heart. There are also increased levels in sex hormones, which change the environment regarding certainly coagulation and other things, and it increases in circulatory volume. You hear us in all of our lectures about PAH talk about keeping our patients on the low end of euvolemia because the right heart tolerates that better, but that is not going to happen in a pregnant patient because that blood volume expands, and all of those things create challenges for a failing right heart. This is just a graph representing what we just discussed. And you can see the changes, the physiologic changes in pregnancy actually happen very early. Our lines start to converge within just a couple of weeks. And you can see maximize even before you around the time of 20 weeks. And so early in pregnancy, you'll often see a patient with pulmonary hypertension who's become pregnant, becoming very short of breath in that first few weeks. And that's because of all those changes. Cardiac output increases in your normal female who's pregnant. However, many of our patients with pulmonary hypertension are cardiac output limited. So now there's increased demand on that right heart without the ability to increase cardiac output. Also, mean arterial pressure falls, and so does systemic vascular resistance in the normal pregnant patient. And so those things can be poorly tolerated in our PH patients who often, both because of drugs and their condition, will run a low blood pressure chronically. And so those changes that happen very early can have a difficult or can have an effect on our patients that they're unable to compensate for, really, unlike folks with normal hearts. So I'm going to present to you a patient who came to me at our hospital. This is a real case. She's a 33-year-old female. She, at the time of presentation, was 30 weeks pregnant with her third child. She's an immigrant from Sudan and had not been to medical care with us before. She came in with complaints of shortness of breath, fatigue, and she'd been syncopal at home. She was also having intermittent episodes of SVT that were picked up in our OBGYN clinic. She denied any history of cardiopulmonary disease, said she was able to carry her other two pregnancies without problem. She denied any illicit drug use. That's certainly an important question to ask, as especially stimulants can be associated with pulmonary hypertension. So methamphetamine, amphetamines, and cocaine, we asked about those things. And she never took diet drugs for any reason. Her vital signs when we met her were these. Her blood pressure was lowish at 90/60. She was a bit tachycardic. As you can see there, oxygen saturation's really at the lower limit of, and certainly lower than they should be for this young woman. You can see her blood gas is there. pH is 7.5, and she's breathing her PCO2 down to 29. That is actually normal in pregnancy. It's thought that progesterone is a respiratory stimulant, so you really should have a gas that looks like that. And you can see her bicarbonate level there. So her physical exam, she has jugular venous distension. You can see on exam, she has a very loud pulmonic component of the second heart sound and a grade 3/6 systolic murmur at the left lower sternal border. Her lung fields are clear. She did have 1+ edema in her bilateral lower extremities, and her EKG showed RVH. Chest radiograph looked good. And you can see both her chest radiograph and her ventilation perfusion scan at the bottom there. You can do ventilation perfusion scanning safely in ladies who are pregnant, not much difference in the radiation dose between that and a CT, and you can shield the baby during the study. But doing that, it's really the best test to rule out chronic thromboembolic pulmonary hypertension, which would have a different treatment plan and certainly involve some anticoagulation. So it was important for us to know that even pre-delivery. We did a couple extra things on her. We checked her for schistosomiasis, given her immigrant status. I always check that in folks that live in endemic countries. It is the largest worldwide cause of pulmonary hypertension. I have not found one yet. Ron, have you seen any patients with schistosomiasis in your clinic?
Not yet in our clinic, nope.
That's one of those things we always look for, and I'm yet to find. Moving on to her other testing, she has echocardiogram showing a dilated right ventricle, paradoxical septal wall motion, and normal left ventricular function, which is good because you always have to also look for patients who have myocarditis at pregnancy. And she did not have evidence of that. Here's her echocardiogram. Ron, since you're the cardiologist, would you go ahead and read that for me?
So this is very similar to what we saw in the first case in terms of orientation, the apical view where the patient's standing on their hands and the right ventricle is on your top left and the left ventricle is on the top right. The largest chamber in view, in my opinion, here is the right atrium. It's not as long as the right ventricle, but it's quite wide. When you see it playing, you'll see that the annular motion is fair. You don't see RV endocardial motion very well. But clearly the chambers are dilated. The left ventricle is not quite as small but the left atrium is as small as in the first case. So this is really severe right ventricular dilatation with at least mild to moderately reduced RV function. So she was seen, admitted. She was given IM corticosteroids, given that she's already 30 weeks, so had a viable fetus. She was given corticosteroids to accelerate fetal lung development while we continued with her diagnostic workup and decided on the plan for delivery of the baby. Her right heart cath is here. Her right atrial pressure is 17. Her PA pressure mean was 52, a normal wedge pressure, and a cardiac output of 4.36 liters, giving her index 2.17. Her PA saturation is 49%, PVR 10.3 Wood units, and she had no response to a nitric oxide challenge and no evidence of a step up or congenital heart disease on that cath. Ron, looking at that cath, in a pregnant woman, what do you think about the cardiac output index and how does that correlate with that PA saturation? Well, the PA saturation is probably the most upsetting here. I think we're talking about hemoglobins that are different. We're talking about two bodies to feed. And so what's mostly bothersome to me is that this is going to get worse before it gets better. And so when the patient delivers, or immediately post-delivery, we're going to see these hemodynamics get worse. And these are bad already, as evidenced by, as you mentioned, the low PA saturation.
Yeah, I think it's important to remember in these complicated patients that these numbers aren't flat. I'm looking at a cath in relationship to what the patient's cardiac output should be. And being pregnant, it should be higher than normal. And here it is not. We see that also in liver patients. They should be running a higher cardiac output to make up for that peripheral vasodilatation that they have, just like pregnant women. And so when you see those numbers, you know they're a little off. So I agree, the PA saturation in this case is showing us that we have critical oxygen delivery and are not getting enough oxygen where it needs to go in the periphery. So she was admitted, as I mentioned. She was put on bed rest because she was syncopal. We don't always do that, but until we get her treated, I'd like her not to pass out in the hospital. She's on oxygen and diuretics, and heparin was also prescribed for this patient because of clotting risk. Her fetal heart tones were noted to be 150 beats a minute, so baby is doing well at this point. Looking at these patients, as I mentioned before on the hemodynamics, you really want to compare them to what they should be in a normal pregnancy and not what they should be in a non-pregnant individual. And so this is just a schematic representation of the same thing we've discussed. Normally, the pulmonary circulation is that low resistance, high flow system. In a normal pregnancy, it becomes an even higher flow system, again, with low resistance. But when we add pulmonary hypertension to pregnancy, now suddenly we have a lot of flow trying to go through a high resistance system, and it causes right ventricular failure. This is another description of what the physiologic changes in PAH patients are in response to pregnancy. And really, you'll see a lot of loops in here because a lot of these things affect something else. So our patient's blood pressure, our SVR, is going to lower by about 10% due to circulating hormones, NO and prostacyclins. We're going to increase our cardiac output if they're able to do so by 30 to 50%, and that's done through stroke volume and heart rate. They're going to have increased coagulability, which we worry about, and increased O2 consumption with the metabolic changes going on, and of course the fetus. And then our blood volume will increase 40 to 100% with increased red blood cell mass. So again, as Ron was mentioning earlier, a different hemoglobin than our average patient. If the patient has congenital heart disease, you're going to increase right to left shunt, and those patients are particularly difficult to manage. And with that coagulability, you can get things like PEs, which will lead to more hypoxia and hypotension and circular, causing more cardiac failure. Just with the increased O2 consumption, we're asking a heart that was already struggling to do more work. And so you're going to see more RV failure and dilatation. Patients can have a physiologic anemia if they're unable to increase that red blood cell mass. All in all, causing increased cardiac stress with a decrease in the ability to compensate for it. And then delivery is that period of time is going to make all of this more difficult with fluid changes and blood pressure changes, as Ron mentioned earlier. Outcomes in pregnancy, we don't have big, certainly randomized studies. So what I'm going to show you is just a few single center studies. They're small. What we did during pregnancy, and here's how it worked out. This is 26 pregnancies reported over a 3-year period to a prospective registry. Successful outcome here is defined as the birth of a healthy baby and survival of the mother without the need for lung transplantation. So you can see they're pretty low, 61.5% successful outcome. I think we can all agree we definitely would like a higher number than that. Death or transplantation for the mom in 15% of cases in this study. Looking at another study, this is very small, 16 patients with successful pregnancies reported out to a multinational prospective registry. And again, this successful pregnancy is defined the same way. So these patients who were enrolled had well-controlled pulmonary hypertension with relatively low pulmonary vascular resistances, although higher than normal. Walk tests were good in this population of patients. And if you look at what kind of PH they had a low percentage of congenital heart disease, and these folks tend to do a little worse with pregnancy. Connective tissue disease related was about a quarter, and then idiopathic the rest. You can see the medications there. I don't use a lot of calcium channel blockers in my patients. This cohort had about half the people on it, and this is what PH medications that they used. Inhaled iloprost, PDE5 inhibitors, or IV epoprostenol. This is another study looking at most patients had PH secondary congenital heart disease. As I already mentioned, those patients are particularly complicated because now you have to deal with a shunt. 17.8% of those patients had Eisenmenger syndrome. Sildenafil was used in 31% of the pregnancies. There were 4 maternal deaths, and 3 of the 4 had Eisenmengers in this. Heart failure complicated 6%, and fetal growth restriction in a little over a quarter. Patients with morbidities, it was more common in patients with a cyanotic cardiac lesion or RVSP on echo greater than 70 millimeters of mercury. And you can see how that plays out there in that graph. Here's one more AIM, and this study was looking at predictors of combined endpoint of maternal death, severe heart failure requiring treatment, or a PH crisis, which I assume looks like it means shock in this study. So 24.5% of women required admission for delivery within 2 days from their presentation. Elective C-section was performed in 95.7% of women. 54% of women received PH therapies during their pregnancy in this, and 6 women died, 33 had heart failure, and 10 had a PH crisis. Patients who met the combined endpoint were more likely to have Eisenmengers, as we already mentioned, or repair defects, even if they didn't have Eisenmengers anymore. Other things were low oxygen saturation, like my patient, pericardial effusion on echocardiography, which again is just a signal of bad right heart failure. Maternal mortality and morbidity remained high in patients with PH-related congenital heart disease. So when we see those in our center, we are particularly concerned, although concerned for all women who come in pregnant who have pulmonary hypertension. So the teaching points out of all those single center reports are really look for early clinical deterioration. We definitely see that. It happens fairly early in the pregnancy. Sudden hemodynamic instability is poorly tolerated in these patients, and so we want to avoid that at all costs. If there's severe RV dysfunction, we're more likely to have problems, as is the other prognostic indicators we follow in all PH patients. So if a patient is pregnant, like mine came to me already 30 weeks pregnant, we are in the pregnancy. There's nothing we can do about that. So how do we monitor folks when they come to you and they remain, and they're pregnant on each trimester? So when I actually get a patient in the first trimester, which we do occasionally, we're of course going to stop everything that's pregnancy category X. We already discussed that. We're going to refer to a high risk obstetrician. We have maternal fetal medicine folks at our institution we work with, and we're going to see them very often in both our clinic and maternal fetal medicine. So monthly visits, monthly echoes, labs and walks, and we're going to optimize that PAH therapy. We may start low molecular weight heparin like I did in my patient's case here. If they're bed rest or inpatient, we usually don't do that as an outpatient. And we are going to recommend therapeutic abortion if they developed right heart failure and discuss the risks with her. In the second trimester, we're going to then add anesthesia to our multidisciplinary team because we're going to have to discuss delivery, how we're going to do that, and what kind of anesthesia we're going to use. We're going to see them every 2 weeks. We may do twice monthly echocardiograms. Sometimes we do once a month during that, depending on how sick the patient is. And then we're going to talk about keeping fluid off so that they don't decompensate with their right heart failure, and optimize that PAH therapy. When we say optimize, and this is out of a consensus document of PAH experts who got together to review what they do at their centers. When we say optimize PAH therapy, what does that mean at your center, Ron?
Well, the optimization is really a loose definition for the expert to say that I'm satisfied that I've given everything I can give to the tolerance of the patient and to the feasibility of the patient. So I think maybe maximize is better than optimize.
I agree with that. Maximize would be a better word there. Most often in our center, this is going to mean a prostacyclin infusion, usually IV at our center, unless the patient has very, very well controlled pulmonary hypertension. And then the third trimester, when unfortunately we do get a few patients who don't know they have PAH and are in their third trimester, or folks who wanted to continue their pregnancy and did well early on. Now we have that anesthesiologist, of course, the high-risk obstetrician, PH physician, and then we're going to talk a lot, and we usually talk weekly about the timing and route of delivery. So we're going to see the patient weekly. We're going to talk as a team weekly to decide when the best time is for both mom and baby to pursue delivery. We usually do not want that to happen in an uncontrolled way. So we're going to try to do it in a controlled way. We will do every 2-week echocardiography, BMPs, walk tests. We're still going to manage that fluid like we would any PH patient. And then we're going to plan on watching the patient in the intensive care unit around delivery, whatever way we decide to do that. We talked about this before, so I'm not going to spend much time on it. There are only a couple of options for patients who are pregnant. You can use prostacyclins or you can use PDE5 inhibitors. So our patients are often on both of those surrounding what is a really high risk time period. So back to my patient, she was admitted and started on IV epoprostenol immediately. We put her on 2 nanograms per kilogram per minute and then up titrated really quickly. We didn't know how much time we had. Many times in an outpatient setting, I'm going to take 3 months to get up to my target dose for my patients, but we don't have 3 months here for this patient, most likely. And so we manage her side effects and go up on that dose really quickly. She was also put on a PDE5 inhibitor. At 37 weeks gestation, while receiving IV EPO and sildenafil, we did a scheduled C-section. That was a little longer than us PH folks wanted to go with the pregnancy and a little shorter than the maternal fetal medicine people wanted to go. And so we made a compromise, and that's where we were. Unless something happened to her, we kept her hospitalized during that time, so we knew what was going on. In this case, because she was very high risk and we really weren't on therapy for as long as we'd like to be, we actually brought in CVTS and then had microcannulas put in case she had a problem during the delivery and we needed to do ECMO. We were all present in the operating room together, CVTS, myself, cardiac anesthesia, and of course, maternal fetal medicine as the delivery commenced. And fortunately, she did well without complication and delivered a healthy baby boy. So if you look at this expert recommendation document, C-section is the recommended mode of delivery. However, vaginal birth has been safely performed, and we have done that at our center in very careful cases. There are pros and cons of each way of delivery. So we're going to monitor the patient really closely with continuous EKG, pulse ox. We often will, in cases like this, might have a Swan-Ganz catheter in. Although PA catheters in document are not routinely recommended, we don't use them for all folks. We did in this patient. Non-invasive hemodynamic monitoring may also be helpful. The risks of vaginal delivery are these Valsalva maneuvers, and that is when our patients often become sick. I don't know about you, Ron, but I have had many of my patients right before a code coming back from a bathroom or doing something Valsalva related. And so we don't want that to happen in our normal patients, but vaginal delivery is a Valsalva maneuver. Have you delivered vaginally at your center, or are you doing mostly C-sections for this reason?
Well, we're doing exclusively C-section now because the last attempts at vaginal delivery, but I mean, they were successful, but they were very, very difficult. Yeah. Too many people in the room, too many things going on, too many things that aren't really under our control. Even pain control, there's a threshold of how much narcotics you can give without too much respiratory suppression, and on and on.
Yeah, it's certainly difficult to manage. After delivery, there's an auto transfusion. They're going to have sympathetic nervous system stimulation because of the pain, and vasovagal responses can occur, which will be poorly tolerated during vaginal delivery. So if one is going to pursue this, effective analgesia is imperative to limit all of those risks, but it is a less controlled situation. Anesthesia, though, is also not our favorite thing in patients who have pulmonary hypertension. So you have to have a very careful anesthesia plan. So we avoid single dose spinal anesthesia because of risk of rapid rise of block height and hemodynamic instability. We're usually going to do an epidural or combined spinal epidural anesthesia with low doses. And then general anesthesia may be needed. And if required, we're going to use low airway pressures, as low airway pressures as we can, and avoid hypercarbia, and consider using pressors before induction to avoid that blood pressure drop we often see right after we intubate patients. So the teaching point here is that around the time of delivery and the first postpartum week are the most vulnerable periods for PAH patients who are pregnant. But the risk goes on to about 3 months post-delivery. And so we're going to keep that aggressive therapy plan for all of that time. Patients need to be monitored really closely, as mentioned. And it may take a little while for them to recover even after a successful delivery. It's not uncommon for it to take up to a year or at least 6 months for patients to get back to their baseline after going through this stressor. And so we want to keep that aggressive therapy until we know our patients have fully recovered. So in conclusion, PH can worsen during labor and delivery, and we're putting a lot of stress on an already struggling right ventricle. Early recognition and treatment with appropriate therapy may reduce likelihood of complications. Elective C-section is the recommended mode of delivery as discussed, and you really need a team. And I think that's probably the most important takeaway from this case. Thank you for staying around with us. Those are our advanced cases for the day. I appreciate hearing from your case, Ron, and hope to see you again at another conference.
Thanks so much, Sonja. There's some really important cautions that you've outlined with this pregnancy. One area of concern as we close this out is that what you've given us is sort of a roadmap to how to deal with labor and delivery and pregnancy in general in PAH patients. But I think most of us would agree that avoidance of pregnancy when you're diagnosed with PAH in a known PAH patient is really the number one and number two on my list.
100%, yes.
Okay, thank you all for joining us.
All right, thank you.